I'm Rachel Harger. I'm just going to quickly get on with introducing the speakers that we have today. Just so people are aware, each speaker will speak for about 15 to 20 minutes, and then once everyone's spoken, we'll have time for some questions and answers. Our first speaker today is Dr. Jeremy Tibble. He's a consultant liver specialist and associate chief in medicine at Brighton and Sussex University Hospital NHS Trust.
Can you hear me? There we go. Thank you very much, Luke, for inviting me. I'm going to I've got quite a few slides, but I will try and whiz through them fairly quickly. I think one of the issues in Brighton is that in actual fact, and across the country, there has been an awful lot of focus on hepatitis C, probably over the last 10 years, and I've been a consultant in liver medicine for 10 years in Brighton. And that's partly because of the fact that hepatitis C really had very few treatment options for it, and yet the treatment for hepatitis C has really developed very, very fast, and therefore, because there is a financial imperative in regards to hepatitis C from the point of view of the companies that are producing the drugs, there's been quite a wide-ranging focus on it. And I think partly the result of that is that hepatitis B has sort of slightly disappeared into the background, and yet hepatitis B worldwide is a much bigger problem than hepatitis C is. We do have very effective drugs for hepatitis B. I'm not going to spend any time on those today, but my last slide that I'll show you is really just the sort of the basic aims of treatment in terms of what we're looking to achieve from the point of view of treatment for hepatitis B. So it is one of the world's most common infectious diseases, and we think that there's around about 350 million people worldwide have chronic hepatitis B, and I'll talk a little bit about acute hepatitis B and chronic hepatitis B. Between 500,000 and 1 million people die every year from hepatitis B-related chronic hepatitis or cirrhosis. And the problem with hepatitis B is that because a significant proportion of patients who get infected in adulthood go on to develop chronic disease, we know that a significant proportion of those patients then go on to develop cirrhosis, which is irreversible scarring of the liver, and the consequence of that is progressive liver failure, and a proportion of those patients will go on to develop liver cancer, primary liver cancer. This just goes to show in terms of where the areas of high prevalence, and not surprisingly areas of Africa, China, India are areas of fairly high prevalence. The UK, in actual fact, and the Scandinavian countries are areas of relatively low prevalence, and I think probably we'll talk a little bit about the impact that might have from the point of view of vaccination programs, in actual fact why Northern Europe has very different vaccination programs to that of Southern Europe in terms of Spain and Italy. Annual incidence of hepatocellular carcinoma, again, you can see that is pretty much mirrors the incidence of hepatitis B, not surprisingly, because the majority of primary liver cancers occur in somebody with chronic liver disease, that is cirrhosis. So it very rarely occurs in a normal liver, unlike most of the other cancers that we tend to see. It's a major global problem. There is a large pool of patients, and the consequence of having a large pool of patients is that this is a disease that is transmitted through blood products, through sexual contact, and therefore the bigger the pool of patients, the greater the risk of transmitting the virus to others. It clearly has a number of serious sequelae, and therefore has a significant economic burden, and that's not unique to the UK. And therefore, I think there are urgent actions needed, and we're going to talk a bit about vaccination programs, immunization programs, but also therapeutic intervention for those patients who are chronically infected in terms of the drugs that we've now got available for hepatitis B. The mainstay of treatment used to be a drug called lamivudine, and we knew that 30% of patients would become resistant to lamivudine. They would develop specific viral type resistance to it. After around 3 years, 30% of patients would be resistant to it. We've now got newer generations of drugs, so the standard drugs that we use are adefovir or tenofovir, that have much lower levels of resistance. What about vaccination? the World Health Organization recommends that HPV vaccination is included in national immunisation programmes. We do not in the UK have a national immunisation programme for hepatitis B, and I will talk a little bit about that. For those who are chronically infected with hepatitis B, so once you've got the virus, then treatment really is the sole option to prevent the devastating consequences of hepatitis B. And it is very effective at doing that. The drugs that we have, as I mentioned earlier on, are extremely good in terms of reducing your HBV DNA levels, so we can measure viral particles within the blood. And in the majority of patients, you can get those levels to an undetectable limit. And Martin will talk a little bit about HIV, where we see a similar thing. So what about the clinical features of hepatitis B? Well, the incubation period, that is the time at which you acquire the virus, to the time at which you may get symptoms, anything is between 60 and 90 days. In terms of whether or not you get a clinical illness, and this is really important in terms of picking it up, because if you don't get a clinical illness as a consequence of having hepatitis B, then the likelihood is that you're not going to pick it up, because you're not going to go to your GP and get tested. If you're less than 5 years of age and you acquire hepatitis B, then less than 10% will actually get a clinical illness. So the younger you are, the less likely you are to get a clinical illness. Over the age of 5 years, between 30 and 50%. The acute case fatality rate, as you can see, is relatively low, so between 0.5% and 1%. But the key here is, in terms of chronic infection, if you're infected under the age of 5, so if you are a child who gets infected through having a positive mother, a hepatitis B positive mother, then you've got something like a 90% of chance of going on to develop chronic hepatitis B. Whilst in actual fact, if you get infected at an older age, so most of the people in this room, if you were to acquire hepatitis B acutely, you've got something like an 80 to 90% chance in actual fact of clearing the virus. And that's one of the reasons why those who are against having national immunisation programmes say, well, in actual fact, we would be immunising an awful lot of people. In actual fact, the majority of people, if they get hepatitis B, will clear it in older age. But the premature mortality from chronic liver disease, 15 to 25%. How do we pick it up? What do we measure? Well, we do blood tests, and this is the sort of the typical features that you see. So you can see in the early stages, you measure what we call hepatitis B surface antigen. So this is the first pink here. That rises up to around about 12 weeks, and those levels then start falling. The next thing is that you start developing antibodies. So the antigen is the bit of the virus that we measure. The antibody is the bit from the immune system that helps to attack the virus and get rid of it. And you can measure two types of antibody, what we call an IgG and an IgM. So the IgM antibody is the bit that appears first, and then in later life we develop IgG. So this is somebody who recovers, the hepatitis B surface antigen rises and then falls, they develop an antibody for it, and the hepatitis B surface antigen then becomes undetectable. This is somebody who doesn't recover, so the hepatitis B surface antigen, you can see this time rises. It doesn't start to fall, all right? So they are then left as being what we call hepatitis B surface antigen positive. And at the top there is another bit of the virus that we measure. So the virus essentially has three bits that we can measure, what we call the surface antigen, the E antigen, and the core antigen. The E antigen is the bit that makes us become infective. So if we remain E antigen positive, so we don't develop an antibody, the immune system doesn't develop an antibody to it, then actually it means that we are likely or have a high chance of passing the virus on to somebody else through sexual contact. And that really is quite crucial in terms of if you become E antigen negative, so you get rid of part of the virus but you remain surface antigen positive, then you're what we call a chronic infective carrier. But your risk of transmission is much lower than somebody who's E antigen positive. This just goes to show in terms of symptomatic, this is a pictorial description of what I was describing earlier. In terms of if you're young, the likelihood of having a symptomatic infection is very small, but your likelihood of developing chronic disease is high, whilst in actual fact, it's the other way around. So the older you are, the more likely you are to get a symptomatic infection, but because you've got a symptomatic infection, in actual fact, the chances are you will clear it. And the reason that you're symptomatic is because your immune system is fighting the virus, and that's why you become symptomatic. So what happens in terms of hepatitis B? Well, Here we go, acute hepatitis B infection. 90 to 95% of neonates, in actual fact, will go on to develop chronic infection, whilst only 5 to 10% of adults. Once you've got chronic hepatitis B, in 15 to 40% progress to liver failure, and that is accompanied with cirrhosis and hepatocellular carcinoma. Hepatitis B generally, as I said, is successfully cleared by the immune system. It begins with what we call an immune tolerant phase, and it lasts for about 45 to 160 days. You then start to clear the virus, and I've said 90 to 95% of acute adults will clear it. Concentration of hepatitis B virus in various bodily fluids, and this is important in terms of routes of transmission. So very high in blood, serum, wound exudates, moderate levels in semen, vaginal fluid, and low or undetectable in terms of things like breast milk. So it's important to realise that in actual fact you can breastfeed in terms of if you're having children, and I'll come on to vaccination of infants born to hepatitis B positive mothers. It's predominantly transmitted through sexual, drugged routes and perinatal transmission. And this generally is the kind of the picture that we see. So heterosexual transmission, 41%. Homosexual activity, obviously in Brighton we have a large MSM population. So within Brighton we see a higher number of patients with hepatitis B than you would expect. Injection drug use, again, high prevalence rates within Brighton. And also within Brighton now, we are getting an increasing immigrant population. Again, that is affecting the rates of hepatitis B that we are seeing within Brighton. What are the objectives in terms of vaccination programs? Well, firstly is to prevent chronic hepatitis B, prevent chronic liver disease, prevent hepatocellular carcinoma, and prevent acute symptomatic hepatitis B. This is a disease that essentially you could eradicate if you vaccinated everybody at birth in the way that we do for a large number of viruses. Then it is a completely preventable disease. So in the States they have a vaccination program preventing perinatal HPV transmission, routine vaccination of all infants, vaccination of children in high-risk groups, and vaccination of all adolescents. So all unvaccinated children at 11 to 12 years are picked up through schooling age, and high-risk adolescents at older ages. This just goes to show what's happened to hepatitis B incidence within America. And you can see the vaccine was licensed in 1981. Hepatitis B screening of pregnant women was recommended in about 1988. As you can see, the levels beginning to fall. Infant immunisation recommended, and then adolescent immunisation recommended in 1995. So you can see a progressive fall in the incidence of acute hepatitis B. What about Europe? Well, it differs across Europe. 47 countries do, 6 don't. If you look at the data from Italy and Spain, where they've got universal infant and adolescent immunisation, which started in 1991, they've had a fall in the incidence of acute infection from 11 to 0.9 per 100,000. Last figure was 2010. In Italy, fall in the prevalence of hepatitis B surface antigen, that's chronic infection, was previously 0.1 to 0.6, and that's fallen quite dramatically. It's currently 0.1 to 0.6, was previously 5.15. And overall hepatitis B surface antigen prevalence in Catalonia, again, has fallen significantly. What about the pros then for vaccination? Well, there is a problem with risk of reliance on targeted vaccination, which is what we currently have in the UK. So high-risk groups are targeted. But you've got the need for continually reaching out to the high-risk groups, so men's sex with men, sex workers, people who have multiple partners, intravenous drug users. Many of those people are not identified until after they have been infected. The uptake rates of vaccination in intravenous drug users, and we did a study in Brighton 2 years ago, 33% only completed their first dose of vaccination in Brighton. That's of people that were eligible, that were seen, they were counselled for it. So 70+% are still, despite knowing the risks, are not taking up vaccination. And similar problems seen in men's sex with men. Problem areas with high immigrant populations, which is increasing within Brighton. But what about the downside of vaccination, the people that would argue against it, well, they would say that the majority of adults clear the virus. The figures would suggest that one adult would have to transmit to 20 others for there to be one chronic carrier, because of the fact that the majority of adults who get it will clear it. And the suggestion is that antenatal screening may be the most cost-effective, high rates of chronicity in vertically infected. So I think there is an argument, and I think probably we can talk about that as a panel. Just very quickly then, in terms of pregnant women and new mums, can I breastfeed my baby if I have hepatitis B? Yes, as long as your baby is vaccinated. So they need something called hepatitis B immunoglobulin. That gives them immediate protection within 12 hours of birth, and they then need to get the three shots. Most babies do not die from hepatitis C, but up to 9 out of 10 babies born to infected mothers will end up being carriers if they are not immunised and they don't get their hepatitis B immunoglobulin. So if you make sure that they get all 3 shots plus the hepatitis B immunoglobulin, they've got a 90% chance of being safe from hepatitis B for life. So this is absolutely imperative, and this is done through the antenatal screening programmes across the UK. So birth, they get the hepatitis B immunoglobulin, plus their initial vaccine. 1 to 2 months old, they get their second vaccine, and then 6 months old, they get the third vaccine. I'll whiz through those. I think this is the key, is that hepatitis B can be prevented. So anybody who's got a high risk of getting hepatitis B, certainly in the UK, is suitable for vaccination. So all of us as medics working within a hospital environment get vaccinated. Martin may talk a little bit about the vaccination programme that they have in the Lawson unit down at the county. And just very lastly, this is my last slide in terms of aims of therapy for chronic hepatitis B infection. There's a number of aims. The first is in terms of changing people who are infected carriers to non-infective carriers, and thereby reducing the risk of transmission to others. So converting people from what we call e-antigen positive to e-antigen negative. The antiviral agents that we use, the oral medications that we use, aren't particularly effective at doing that. So there is a group of patients, in actual fact, who we think may be suitable for being treated with a drug called interferon, which is the same drug that we use for hepatitis C. The longer term goal is in terms of those patients who either you have failed to convert them from e-antigen positive to e-antigen negative, or those who are already negative but are what we call chronically infective carriers, is in actual fact to reduce their viral load and therefore render them what we call HBV DNA negative. So that's get the amount of virus in the blood down to an undetectable level, and thereby preventing the long-term sequelae of chronic hepatitis B. And the drugs, as I say, that we have for that are extremely effective. Thank you.